certainly are too. That's a tough act to follow, I have to say. I've never done any nerve conduction surgery. I haven't transplanted any hands, but I really feel like what we do at CDC, both in the polio arena as well as the measles arena, is really special, and I would describe it as a holy mission, and I think we're saving lives, and I'm proud to be part of that. 2 days ago I started my 32nd year at CDC, and I can't imagine having spent a career in a place that I've enjoyed more or felt like I've had the opportunity to do such great work and work with great people. So I'm very proud of that. So today I'm going to talk to you about measles. I'm sure you've all seen the news. The world's a mess right now, including the United States, unfortunately. And it all comes down to many of the same challenges that we're seeing with polio. We're just not able to vaccinate the people that need to be vaccinated, those who are still susceptible from two terrible viruses, one polio and one measles. So measles is one of the most contagious diseases ever known, and it still is a leading cause of morbidity and mortality worldwide, particularly among childhood populations. It's a respiratory virus, so unlike polio, which is fecal-oral, measles is transmitted by a cough or a sneeze. And what makes it so challenging, one of the many things, is that if a child is infectious in a waiting room at a doctor's office, for example, and sneezes or coughs, that virus will stay in that office for 2 hours unless there's proper ventilation. And so isolation of children who have suspect measles, fever, rash, it's very, very important to isolate those children so you don't have this airborne virus that can infect people for up to 2 hours after the child leaves the room. The only reservoir for measles virus is humans, and unlike polio, there's just one serotype, and the vaccine that we use is very effective for that serotype. In the blue insert, I hope that you can see that. It doesn't look like it's very well projected, so apologies for that. But measles is actually one of the most infectious viruses out there. And this slide just shows, this insert shows just a comparison between the infectivity of a virus like Ebola, which will infect 2 to 3 people on average in a population of people that are totally susceptible. And you have one person with Ebola who's shedding virus. 2 to 3 of those people will be infected. For polio, that number is 5 to 7. For measles, it's 12 to 18. We generally say it's about 17 people that will be infected by an infectious person who's shedding measles virus in a population of susceptible individuals. So it's a very, very infectious virus, and that makes it very tough to control. You have to be quick, and you have to have good surveillance so you can identify a suspected case and then react to it. So it's very important to have strong surveillance, like it is with polio. I'm not sure that many folks have actually seen measles in the United States lately, but it's an acute febrile rash. The rash is typically macular papular, which is shown in this slide. Essentially, they're flat and bumpy skin changes, and it starts on the face and then rotates or moves down to the rest of the body. It's characterized by high fever and at least one of the 3 C's, as we call them, cough, coryza, or conjunctivitis. And our surveillance definition for a suspected case of measles is a child with a rash and high fever and cough, coryza, or conjunctivitis, although that's changing as we approach measles elimination in the world, which is a very exciting thing I want to talk a little bit about. One of the challenges of measles control and elimination is that it has a very long incubation period that can last up to 3 weeks. And that makes it difficult because the person can actually be exposed and then get on an airplane and arrive in Rockdale County, New York, and surprise, surprise, 3 weeks later you've got cases of measles in a population that wasn't adequately protected. Another challenge with measles virus is that it is infectious in general 4 days before and 4 days after rash onset. So actually before you even have a rash, you can be shedding virus and infecting others. So it makes it a bit challenging. And then the rash lasts about 4 to 8 days or about a week after onset. Frequent complications. Measles in the developing world, like the United States, really isn't a very serious disease, although it can be. But in places where I spend a lot of my time in the developing world, it's a huge challenge. It's a deadly disease. Some of the complications from measles include otitis media, inflammation of the middle ear, diarrhea, pneumonia, and keratitis are inflammation of the cornea, and then, worst case scenario is death. Here's some pictures of some tragedies that have been caused by measles. Cornea scarring causing blindness, and that's due to vitamin A deficiency, which is really quite common in the places that we work outside the United States. Peeling of the skin, and then encephalitis, which can lead to chronic disability. It's very sad. It's not just, you get spots for a week and then everything is fine. This is not the kind of disease that we're seeing. The risk factors for measles complications, it's most dangerous in infants and in adults, in persons with poor nutrition, including vitamin A deficiency, and then in folks that have immunosuppression, either due to things like HIV infection or who are on immunosuppressive therapies. Measles mortality, as I said, it's highest in children who are less than 1 year of age, and also in adults. And it can kill between 0.1 and 10% of people who are infected. But in humanitarian emergencies, which we see throughout the world, mortality from measles can actually be as high as 1/3 of people who get measles. So this is really a very, very dangerous disease. And often one of the first responses that will occur in refugee camps when refugees are crossing borders, for example, will be that the people are vaccinated for measles vaccine because it's such a deadly virus. So it's really frontline important treatment. Just want to talk very briefly about the measles vaccine itself. Unlike oral polio, but like inactivated polio vaccine, it's a shot. It's a live virus, and it has to be reconstituted. And its effectiveness, it's a very, very good vaccine. But the efficacy of the vaccine, which means the people that are protected from the vaccine once it's given, of course, vary at the age of vaccination. So it's as low as 50% at 6 months of age, and then can be 95% as children reach their first birthday. We need 95% of a population to be protected, to be immune to measles virus. So if a virus is introduced, it doesn't spread. And so if and that's this concept called population herd immunity. You probably have heard about that on the news and your science classes, I'm sure. But the one dose of vaccine given at 12 months only produces 95% coverage, or 95% seroconversion or immunity, and you're very rare. That's with 100% of your population that is vaccinated. So you very rarely get that sort of protection from or you very rarely get 95% of your population immune from one dose of vaccine. So we now routinely provide 2 doses of measles vaccine in the United States and throughout the world. And the vaccine does produce lifelong immunity. The vaccine comes in several different formulations. You have single antigen measles vaccine, you've got measles rubella vaccine, measles mumps rubella vaccine, which is used in places in the United States, and then measles mumps rubella varicella vaccine, which is also used in the United States. And the measles component of those 4 different formulations of the measles vaccine is equally effective. So, for example, MMR, the measles component of that, is no less, no better, or no worse than the single antigen measles vaccine. This is just an illustration of the graphics aren't working here, but it's an illustration of why we need 2 doses of vaccine, and essentially it's what I just said. The vaccine, even best case, given at 12 months of age, for example, only produces 95% immunity, and we need 95% herd immunity to stop outbreaks when the virus is introduced. So you really do need 2 doses to get those kids who didn't get immunity from the first dose of vaccine. And then the second dose also provides a second chance for the kids who missed the first dose to get their first dose. So it's not only a chance to seroconvert those who got their first dose but aren't protected, but also those who missed their first dose. So we call it a second opportunity for measles protection. And that's a very important point. Measles coverage, what's happening globally is very interesting. So before you introduce measles vaccine, you have a lot of circulation, and you typically see measles outbreaks that occur every 2 to 4 years. It's very, very predictable, and of course most cases are unvaccinated, and most cases occur in young children, less than 5 years of age. And once you get measles infection, then you're protected for life. So in places that don't commonly use the vaccine, you get measles as a young child, and then you are protected for life, assuming that you survive the infection. In places where you have high or intermediate to high immunization coverage, that actually spreads out the distance between measles outbreaks, and you start seeing cases in older children, adolescents, and adults. And that's what we're seeing now in the United States and in more of the developed countries throughout the world. We're seeing a lot of cases, for example, in Eastern Europe. A lot of countries now are experiencing measles outbreak in Eastern Europe, and many of those cases, a large part of their case populations are in adults, because these are adults that have not been vaccinated as children, and because they haven't had a lot of measles circulation in their country, they essentially remain susceptible as they age. Then they get a big virus introduction, and you get an epidemic or a huge outbreak. So that's what we're seeing right now. The bar chart just shows, the blue bars, if you can see them, I hope you can, just shows the reduction in measles cases that we've seen from 1980 through 2017, and the increase in coverage. In the blue and the red are both coverage rates for first dose measles vaccine, and they've been hovering now for several years, probably about 5 or 6 years, in the mid-80s. I think global coverage now is 86%. And again, we need protection at 95%. So what we really aim for is 2 doses of measles at 95%. What we're seeing globally is 1 dose of measles at 86% on average. So we have quite a challenge in front of us. Much like polio, the kids who need the vaccine the most are the hardest to reach. And so we're sort of all being challenged by the same sorts of things. And this is just another illustration. The green bar actually is another way of looking at coverage over time. It's a little easier to see that. And then the blue and the red lines actually represent second dose measles, measured in 2 different surveys. It's a more complicated slide than it needs to be, but basically the coverage of second dose measles is at 69% right now. And again, we want that to be 95%, so we have our work cut out for us. I put in 31 years at CDC. I'm going to need at least another 31 to tackle that problem. 10 countries in the United States account for about 60% of the unvaccinated children, of which right now there are about 19 to 20 million unprotected children in the world. And you see from this slide just where those countries are. So the size of the circles just indicate the relative size of the number of kids in those different countries. So the big problems, of course, are Nigeria, India, Pakistan, and many of the countries that had big polio challenges 10, 15 years ago. So we're seeing very similar challenges. Measles outbreaks, we've seen a huge resurgence in the last 2 years. This slide just shows cases over time. And you see that in 2018 and then in 2019, we've really seen a huge resurgence of cases. And that's globally. And here's just a slide that shows some of the outbreaks that I'm sure you all have read about in the newspaper. It's very interesting. The bottom line for why outbreaks occur is that people aren't vaccinated. They're not vaccinated, however, for many, many different reasons, and that varies in different locations. For example, this slide shows a big outbreak in Ukraine, 74,000 cases. Ukraine had very, very high coverage in 2008. It was at 95% with measles vaccine. They had a death after measles vaccine was provided to a child. The death was not associated with vaccination. In 2016, the coverage had plummeted to 31% in Ukraine. That was in 2016. In 2017, guess what happened? Measles virus was introduced. In 2018, they had a huge outbreak this is 74,000 cases, but Ukraine actually, I think, is higher than that right now. And in the first 6 months of 2019, I think we've already topped 50,000 cases in Ukraine. And that was all about this fear about the vaccine, and then the political crisis in Ukraine hasn't helped at all. There was a huge outbreak in Madagascar this year that we've been dealing with, and actually I think is a huge success story because the Madagascar government really took up the challenge and has done a fantastic job controlling that outbreak. But they actually had more than 100,000 cases, and it topped 1,000 people that died from measles in Madagascar. Preventable deaths from 2 shots of a vaccine that costs about $1. So it's really a tragedy. Lots of other causes. Just very interesting. In the Philippines, there's another issue with vaccine hesitancy there. They had a problem with a dengue vaccine that they were administering, and it got the public not only to say dengue vaccine is bad, but they had sort of this halo effect, and they went from dengue vaccine being bad to all vaccines being bad. And of course, that includes polio, and of course that means that immunity levels in the population decrease. And probably most tragically is an importation that occurred in Venezuela. As I think we all know in this room, the Americas, that include South and Central and North America, was declared both rubella and measles free in 2014, 15, 16 in that general area. And unfortunately, the measles importation in Venezuela lasted longer than 1 year. And that then moves a country from being eliminated to endemic. So Venezuela has lost its elimination status. The virus spread to 9 other countries in South America, including Brazil. Brazil has had now continued circulation for over 12 months. So they've lost their elimination status. And what we're facing in the United States right now is in 1 month, in September. Say again? October. Okay, that's good news. More time. In October, if we're still seeing measles circulation of the New York virus, is that correct, Mark? The United States will lose its elimination status. So this is a tragedy. I always tell this story. I'm probably need to speed up, but I always tell this story. I was in a meeting in Geneva a couple of months ago, and we brought in all the immunization focal points for measles into Geneva, and the woman that works on measles for the Americas was there. Her name is Desiree Pastore, and we were all going around the room and talking about our experience with measles outbreaks, and it was Desiree's turn, and she started crying. And she said, "We've been working so long and so hard, and we reached our goal of elimination. And what has happened is we got too comfortable. Folks started thinking, well, measles is a thing of the past. It's not something we need to worry about anymore. Vaccine coverage levels started dropping. Other countries haven't gotten their act together the way that the Americas did, so there's still measles circulation in the world. Venezuela had an importation. South America blew up. So 2 lessons learned there for me. 3 actually. One is that you can never let your guard down. As long as virus is circulating anywhere, it's a risk in your neighborhood. And that goes not only for measles, but of course polio. You know that better than I do. And the other lesson is that we really need to work on controlling global outbreaks of measles and polio, because as long as, again, there's virus there, there can be virus here. And then thirdly, For me, the lesson learned was that if a country and a government and global partner organizations like Rotary commit to doing something, they get it done. The Americas eliminated measles. They kept it eliminated until there was this tragedy. They got comfortable. But once they had this outbreak, folks came together, they rolled up their sleeves, donors provided money, and now these outbreaks are getting under control. And it really shows what true high-level political government commitment can do when faced with the crisis. And for me, that's a real victory. Okay, moving on. Here's, I don't know, Mark, if you, maybe on the first measles talk today, or the only measles talk, but here's the current situation in 2019. I think maybe these numbers are a little bit off. I think these are about a week ago, but we're now over 1,100 cases of measles, that's a tragedy. So what's the root causes? I've already covered this a little bit. Essentially, it's kids not being vaccinated, and that's from many different causes, including health systems that just can't deliver vaccines when they need to. Children that don't have access to vaccines when they come in. A clinic might be closed, or healthcare workers on lunch break. The mother has walked 3 miles and can't do it the next day when the healthcare worker might be available. Civil unrest, famine. I mean, these are all the same things that you face in the polio community. And then this issue that we're hearing more about in the news is vaccine hesitancy. And that's certainly a problem, but I think we can't lose sight that although there are communities of people, particularly in places like the United States and Western Europe, who haven't seen these diseases in so long, they think the vaccine is worse than the disease. The real problem globally, at a global level, is kids not having access to vaccine. It's those kids not being vaccinated. Parents want to do the right thing. Kids are going to get vaccinated if healthcare workers tell their parents to get their children vaccinated. There's not going to be a mother in Tanzania that brings her child to a health clinic and says, well, you know, I read this internet article. That's really not what's happening. It might happen in Rockdale County, New York, but that's just a small part of the world. And of course, global spread, it's all the same with polio. You know, we've got airlines that just are great vehicles for transmitting virus. And the issue with measles, again, is because you can have up to a 3-week incubation period. You know, it becomes not uncommon that someone who is exposed to measles could get on an airplane, or many people could get on airplanes and spread the virus all over the place. So there is a strategic plan for measles elimination that was written for the period of 2012 through 2020. It's now 2019, so we're working on the 2021-2030 strategic plan for measles and rubella. But the 5 strategies in the 2012 to 2020 strategic plan are still good. They're still effective. The challenge that we have is they're not being implemented as well as they need to be. And that's the same with polio. We have to achieve high population immunity. We have to conduct good surveillance, so we identify children with fever and rash early. And we have the vaccine on hand and the trained workforce on hand to react quickly. For measles, it's very interesting. Responding to an outbreak quickly is more important than actually doing 100% of the population covered. Rapidness is really key with measles because it's so infectious. So we need to develop outbreak preparedness and response. We need to build public confidence and make sure that there's demand, that people know that they need to get vaccine in the face of an outbreak. And then we're always, like the polio community, performing research. 2 of the very interesting things that my group at CDC is collaborating with is a test that can be used in the field, and it's going to be implemented much more broadly very quickly, in which you've got a case of fever rash, a child with fever rash sitting in front of you. You don't know what it is. Is it measles? Is it rubella? Is it dengue? Is it who knows what? You take a finger prick of blood, and with that finger prick of blood you can actually tell tell whether that child has measles or rubella virus. And then, of course, you can react to that information. So this is a real game changer. Another game changer, CDC has been working with funding from the Gates Foundation with Georgia Tech, and there are 2 other efforts to develop the same thing. But we're working on something called a micropatch, which is, like IPV, I mentioned this, measles vaccine is an injection. So you have to have somebody who knows how to provide an injection safely, and then you have to know what to do with that injection equipment after it's been used. You don't want to just throw it away because someone might come along and say, oh, I want to use that needle for my illicit drug use or whatever, or reuse it on the next patient. So you have to have waste management. And what we're working on now is this micro needle patch, it's called, which is essentially about this big, the size of a small Band-Aid, and it doesn't require any cold chain. You don't have to keep it cold like you do with measles vaccine, like you do with polio vaccine. Anyone can apply a Band-Aid to a child's arm or an adult's arm, and you get very, very high immunity. We've seen high immunity in primates, I should say, and hopefully in the next 3 to 5 years we'll actually start testing in humans. And this really is a game changer. And it could be used not only for measles and rubella, which we're seeing very good results from, but also for other vaccines. So that's really, really exciting stuff. I actually have a prototype in my bag. If there's time to show that to you, I'd love to. I don't travel without it. So why do we work on, I'm the chair of the management team for the Measles and Rubella Initiative, which is very similar in concept to the Global Polio Eradication Initiative. This is a consortium of global partners that have come together to work on a common goal. And for GPEI, that's eradication of polio. For M&RI, Measles and Rubella Initiative, that's a world free of measles, rubella, and congenital rubella syndrome, which is the adverse outcome of rubella infection in women who are pregnant, particularly in their first trimester. It's a tragic syndrome of diseases. And the reason why we aren't just targeting measles, but we're also targeting rubella is really very straightforward. Rubella elimination is actually easier than measles elimination. The vaccine is more effective. And the surveillance that's required for measles is the same as the surveillance required for rubella. And let's see, and rubella is actually less infectious than measles, and because the virus is more infectious, we're actually seeing in several countries that have been administering both measles and rubella combined vaccine that they've been able to eliminate measles, or eliminate rubella before they've been able to eliminate measles. So we actually think that when the world finally decides to set their mind on a measles eradication goal, please God, in my personal opinion, and that will also be joined hand in hand with the rubella goal, that rubella will be the first of the 2 diseases to actually be eradicated. So we're excited about that. This is a slide that shows how we're monitoring progress towards elimination of measles. And again, we have particular coverage targets, we have incidence targets, and then we have mortality reduction targets. And I think this is the general approach that the polio program uses, and I won't go into those. But this slide just shows that just how well we're doing. So the MCV1, that means the measles-containing vaccine 1 indicates first dose of the measles-containing vaccine. We want greater than 90% at the national level. As I said earlier, 86% of countries now globally have MCV1 coverage of 86%. So we haven't quite met that milestone of 90%. And remember, the real goal we want is 95%. So this is just an interim milestone. And 61% of the member states, of the WHO member states, I think there's 194 if I remember correctly, they change. 61% have met this target, so we've got a ways to go. And I won't go through all of this except to say that if you skip down to the measles mortality reduction of 95%, this is another real success story. We haven't reduced measles mortality yet compared to 2000 to 95%, but we're now down to 80%. And that means that we have saved since 2000 21.1 million children's lives. And for me, that's just mind-boggling. I'm really feel so honored to be part of this. Here is just a map showing measles first dose coverage and how we're doing. The blue is good, the red is bad. The darker the nearer the color to red, the worse. So you see we've got huge challenges, particularly in the African continent. But I have to say Africa is committed and they are showing real progress. We're very, very excited about what's happening there. Here is measles incidence. It's particularly bad now in 2019. I think this map would probably look even worse, but we've got red all over. And so we've got challenges ahead of us. And this is what I just covered in terms of measles reduction. We want 95%, but you know what? 80% isn't that bad, is it? 21.1 million kids saved is not so bad. And this little pie chart up there shows exactly where, what regions have benefited the most. And no surprise, you see that the African region is the region that has had most kids' lives saved. There's also this nice insert down there, but it's so small you probably can't see it, but it just shows the comparison between 2000 mortality and 2015 mortality by region. And you see that the reductions really are seen in Africa because of the big countries there like Nigeria and DRC, and then Sierra, which is Southeast Asia, and of course India is the big challenge in Southeast Asia. So real success. I mean, we still have challenges, but we're working towards it. So the exciting news, like we don't have a global eradication goal for measles, but each of the regions of WHO, there are 6 WHO regions, each of those regions has a measles elimination goal on or before 2020. And 3 of those regions actually have rubella elimination goals on or 2 are actually have target dates, and 1 just has a goal of eliminating rubella at some point in the future. Now, unfortunately, the Americas has lost their elimination status, as I said, and there is actually no region right now that is on track to reach their 2020 goal. I was in a meeting 2 weeks ago in India with the Southeast Asia region, and they've decided that they admit that they're not going to reach their 2020 goal, but they have decided to recommend to their highest advisory board, called the Regional Committee, resetting a regional elimination goal for measles of 2023 and add a rubella elimination goal that is aligned at 2023. So that's really exciting stuff. India is completely committed to reaching that goal. They're doing a mass campaign, 3 phases of a campaign in which they're immunizing millions and millions of children with an injectable vaccine, and they're doing it right. And their incidence rates are declining. It's very exciting stuff. The Indian government is very supportive of this, as is the regional director of the Southeast Asia office of WHO. So it's really an exciting time for measles in Southeast Asia region. I sit on the Regional Verification Commission for the European region of WHO, and we now, I could show you, in Europe we now have 37 of the 53 countries that have eliminated measles. Unfortunately, this is 2018 data. Based on 2017 data. It's 2018 results based on 2017 data. We just had a meeting a couple of weeks ago and the results aren't quite this good, but there's progress being made there.
And you see where we are with the other regions. Africa hasn't come far in terms of validating elimination, but they're getting started, and I think that we'll soon have some countries that have been verified. So it's an exciting time. Western Pacific region is on board. They're doing great work there. And then I just wanted to say a little bit about the Rubella and Measles Initiative. Like the polio eradication program, the Global Polio Eradication Initiative. We have founding partners. We've got WHO, UNICEF, CDC, of course, the American Red Cross, and the United States, the United Nations Foundation. And we work very closely with national governments and civil societies and donor organizations, and in many countries with Rotary International, to work on both measles and rubella. It was formed in 2001, and it's a dynamic organization. And our vision is to globally coordinate efforts to achieve a world without measles, rubella, and congenital rubella syndrome. And very much like the GPEI program, we serve in this coordination function. So we get all these diverse partners to come together and try to coordinate and not duplicate and not conflict their activities. And those activities involve fundraising, communications, building strong surveillance networks, of which CDC is the primary funder of those surveillance networks. I think we have 703 measles labs globally, somewhere around there. And then you see the rest of the kinds of things that we do. The next steps, and this is my last slide. So in the development of this next decade of how we want to approach measles and rubella, clearly we need to work very hard on implementing the strategies that we know work, doing a better job providing measles first and second dose vaccine, both through the routine program, that would be like bringing your child into a health clinic, as well as SIAs, which polio has led the way on, SIA implementation. We have to do a much better job addressing our outbreaks, getting in there, identifying them early and responding quicker. And then finally, there's a lot of discussion right now at the global level and at the regional level about setting a date, at least within each of the regions, resetting a target date for measles and rubella elimination. CRO, Southeast Asia, has decided to go ahead and set a date of 2023. It's unclear right now whether the 5 other regions will actually be setting target dates. They're all committed, though, to elimination, and so there's a conversation going on, and I actually think there's some very good signs that I think the regions are really going to push very hard at the upcoming World Health Assembly to keep the global community committed to reaching regional elimination for both measles and rubella. So it's a very, very exciting time now. So thanks very much for your time. I actually have 2 minutes to spare, so if there are any questions, I'd love to keep talking. Thank you.